Esteros Health Data Foundation is doing exactly what this first panel will be about. That's why the description and the intro to them is made through the panel. And I will ask Mirela now from our Sustainability Working Group as well to join here and introduce this fabulous panel. And I just wish you an exciting next few minutes.
Is this open? Can you hear me? Yes. So welcome from my side as well. I'm very happy to be here today. And to be honest, I didn't really want to moderate this panel. The reason is simple. I have nothing to do with decentralized healthcare. I come from the most boring industry in the world, insurance, sorry. Everyone does mistakes. However, when I got in touch with the panelists, my wonderful guests you're gonna meet soon, I realized these people have passion and they understand the topic way better than I do it. And however, I'm gonna be affected because I'm a patient and I've always been asked by my healthcare providers, what's your background? Just to know how much do I need to dumb down what I'm telling you? And blood test results, no, sorry, you don't understand that anyway. So please allow me to welcome our guests today, Thierry, Kate, and Caroline. And just to start properly, I would kindly ask you to introduce yourself briefly and tell us not only what is your background, but what are your hopes and concerns when it comes to decentralized healthcare. Thierry, do you want to start?
Yes, so welcome everybody. My name is Thierry Fumeaux. I'm a physician by training. I'm currently the medical director of the East London Clinic in Geneva, and I've been for more than 15 years the head of an ICU and internal medicine in a regional hospital in Switzerland. And I'm not an expert in blockchain and all these new technologies, but I'm quite interested in the way we can use that in the future. And I see that there is a paradigm change that is coming, and so that's a good reason to be here. Thank you.
Thank you very much. Okay. So start. My name is Katarzyna Wac. I'm a professor of computer science. I lead the Quality of Life Technologies Lab at the University of Geneva, where we leverage different data sources for quantifying daily life, behaviors, health, and quality of life in long term in healthy and disease populations, and I'm also not an expert in blockchain. However, I have something to say about decentralized health and also specific personalized, preventive, and participatory way of keeping us all healthy. Thank you.
Thank you. My name is Perrin. I'm directing the Geneva Digital Health Hub. The hub is based at the University of Geneva. It was co-founded with the Swiss Agency for Development and Cooperation. So I'm going to bring a little bit the global health perspective, I think, in the discussion. The hub was co-founded in 2021, but it's really based on 20 plus years of experience of implementing digital health in LMIC, so the RAFT e-learning and telemedicine network, but also through experience we had in the hospital here and in a more European context. And what we learned is that you have challenges that are very different in a different context, but then there are challenges that are exactly the same. So what we are focusing on is really how can we learn better from previous implementations, how can we connect different stakeholders better, and especially how can we better connect policy and implementation layers.
Perfect. Thank you for the intros. Now, let us structure discussion a bit. First part is going to be the first series of questions around data ownership. What does it mean? What can I expect as a patient when it comes to data ownership? Second part is going to be about data sharing. And last but not least, what are the benefits for me as a patient, if any? So I'm going to start with you, Kate, because we had a very passionate discussion when we got to know each other about patients that have to beg for their blood test results or detailed medical reports sometimes, and I know you have a very strong opinion here. So what does true data ownership look like from a patient perspective?
Thank you very much for this question. And first of all, I will need to notice, is that really an ownership, or we do have a rights to access the data? That's what's happening, right? The hospitals, the clinics, the healthcare system is owning the data, and then the patient has some specific rights to access and ask for copies. And what I think it's really interesting and important to see what we see also with research and development is the data. I would like that the data more and more works towards our advantage, meaning keeps us healthy. Because right now we are, as many of our colleagues mentioned, sick care. We are really practicing sick care. We're going to the doctor when sometimes it's too late, and then specifically the data being there is like there's treatments, and why we are not getting earlier this particular inputs from the data, keeping us healthier, being easier to share, and but I'm not really talking just about clinical data. 60% of our future health state depends on day-to-day conditions, behavior, sleep, physical activity, nutrition, smoking, alcohol. We all know it, and we all know we should behave better. And why not all this data could then work towards our better future health, and from this descriptive data to more prescriptive that will help us day by day change something, that the future outcomes will be better. Thank you.
So I guess you can see the passion here, right? The next question is for you, Thierry, because healthcare IT systems are a bit more engineering driven, like pretty much all the IT systems, let's be honest, and not that much patient-centric. So how do you see a patient-centric system being designed? And are hospitals like yours, for example, ready for that?
Yeah, it's a very interesting point. I think that as physicians, we've been working in very fragmented systems where the data is, as you mentioned, owned by the hospital or the caregivers and not by the patient. So accessing to the data is always difficult, and even I would say transforming the data in information for the physician is very difficult. There is also the fact that culturally I think we are not ready. I mean, most of the hospital, they don't see why they should transfer the data to the patient and give this data to the patient. So for me it's really something that we need a paradigm change, and of course, there is the technology behind, but I think, first of all, it's a kind of human or cultural change that we need, so that people change their mindset and realize that having the data owned by the patient, where the patient has the control to share with the physician or the other caregivers what he wants to share, is something where we can all benefit: the system, the patient, the citizens, and we as caregivers.
Yeah, that's a very important point, and this leads me to another question, because systems are not omnipresent everywhere. And I know that you, Caroline, have a very extensive experience in emerging markets. You had projects in Mali, in Nepal. How does data ownership for patients look like in these geographies?
Thank you. Yeah, we currently run 2 large-scale projects in Mali and Nepal, where we're scaling to over 100 health posts in both countries. And in many of these settings where we work, discussions around data ownership looks very different than the discussions we have here. What we currently see in Mali and Nepal is technically the patients are owning the data, but on paper. So we are in settings where we still paper-based prescriptions and so on. So we implemented telemedicine solutions where we are connecting rural care professionals to medical higher level of care in the central hospitals. But all the data, the discussions is still remaining on paper. So patients have ownership, but no empowerment. And ownership is not enough. I mean, we need the patients to really be able to understand, use and act on the data they have access to. There are a lot of barriers in these emerging markets, which are often similar as the ones we have in higher income settings. Also, there's fragmented health systems, interoperability is an issue, limited digital literacy and low trust sometimes also. So right now our focus in these settings is really also on creating the kind of digital public infrastructure that is needed to have electronic medical records. And we believe that blockchain could play an important role in that, because it can help to manage consent, it can help to ensure traceability and access. So for the moment, we are not using it, but I think in a global health context, it's definitely a technology that's really interesting and important, particularly also when it comes to electronic medical records and digital wallets that include a medical record.
We like this perspective, and especially because you mentioned in one of our previous conversations that digitizing does not mean digitizing the existing analog systems. It's a whole revolution in terms of building something new. So if we speak about data sharing, how should decentralized data sharing work differently from the current hospital to hospital or healthcare provider sharing?
Okay. So I think before we speak about decentralization, it's important to remind that digital health is more than just data sharing. It's part of a broader ecosystem. So we are in a process where we've digitalized our entire society, from computers to mobile phones to genomics, where biology is available as data now. And this really creates an enormous amount of data. Health information systems, social media data, WhatsApp. I mean, there are so many different Internet of Things and so on. And the real promise of digital health lies in really connecting and making sense of this information and being able, and theoretically we should be able to be a little bit smarter about the way how we treat patients, how we prevent care and so on. But that only works if the underlying processes and responsibilities are redesigned, not just the technology. And I think it's a little bit like in the early days of electricity. People replaced steam engines with electricity, and in the beginning the productivity increases that we saw were very little. And it's only when they really started thinking about how to redesign the processes that electricity became the change agent that we see it now. So the goal isn't, in my opinion, to digitalize existing systems, but really to take advantage of the technology in rethinking processes. And in that case, being in an emerging market can sometimes be almost an advantage, because you don't have existing legacy systems in place that you try to digitalize, but you think a little bit different about the processes when you do not have the legacy systems in place.
Yeah, and sometimes emerging economies are doing a leapfrog and adopt the newest and greatest technology.
Oh yeah, we can actually learn also in
Exactly.
a bi-directional way.
Yeah. I like very much your electricity comparison, because this is something which Thierry said some time ago, that AI and blockchain it's a paradigm shift. It's like bringing electricity to the village, you mentioned. And I would like you to elaborate a bit more on that. In terms of sharing data with multiple specialists, how would this work? And is the healthcare system ready for it?
Very interesting. First of all, no, I think the current healthcare system is not ready. I think, again, that's a cultural change that we have to go through. And many people see AI and all these new technologies just as tools, and they don't see that it's a driver for a massive change in the way we work. And I think one important point is that, first of all, we should go from technologies that were developed by engineers for end users, patients or physicians, and this is a failure. We see that every day. I mean, in Switzerland, we used to have the bond that dossier électronique du patient, and this is exactly the proof that it will not work. And I don't know any physician in a hospital who is happy with the electronic health record he's using. So we should change. We should develop tools that are made by engineers with end users, and I think that's the first thing. And second, the fact that in the cultural change, the fact that the data is not owned by the caregiver or the hospital, but by the patient, is something that is also very important, because the patient must be empowered and know exactly what data he owns in his wallet and with whom he can share this data, for what purpose, and what is the advantage that he's going to take. And I think that to get back, are we ready? I don't see many people understanding that. But I think that we have to work on that, empowering people And there will be a lot of positive effect in the efficiency of the system, in the health literacy of the population, and also in the participation of the population. But there's a downside. We must be very careful. Data does not mean information. And there will be a lot of data that are not useful, that are crap, and only commercial data. So curation of the data will be another challenge.
Thank you for that. Kate, I'm going to go to you now because when we discussed, you mentioned that your lab integrates several types of data sources. Is self-reported wellness data, is sensors, is healthcare data, environmental factors. And when we design sharing systems, we need to take into account these very complex correlations in data and also allow patients to control who has access to what.
Thank you very much. Exactly. I will first echo with what Thierry said with respect to the digital literacy and also aspects of usability and usefulness and really co-designing with the users and meeting them whenever they are. There's too many systems being engineered by engineers who love their technologies. And unfortunately, we're really seeing the failure of some of them. So we need to meet the individuals, then including the layered consent of respect to data sharing with whom and what. But it needs to be designed in such a way that it's not so-called black pattern, like you click something and then somebody else on the other side of the globe has your data immediately. Because as we have if our credit card numbers leak out or something else, we may change them. But our health data, unfortunately, it's not something we can change. And the most sensitive and really private data, the genome or our personal predispositions or current diseases or medications, this is really something which should be shared with very, very informed consent and should be designed this way. And then this particular context awareness, and that's where in my lab, when I set up a quality of life technologies lab, and I was like, oh boy, what did I get into? Quality of life, there exists 172 different models of quality of life from different perspectives, the medical, policymakers, developmental, psychological, sociological point of view of quality of life is different. And when I studied all of them, then we decided to have a physical health, follow the World Health Organization quality of life model, physical health, psychological health, social interactions, environmental, holistic point of view on the behavior, health, and quality of life. And that's what needs to be included. And now we have multiple projects running in the lab, and we'll be having a population of Geneva following and also consolidating different data sources together with environmental data sets and typology, transportation, specific API, looking into who is using which particular line and how busy they are and how much noise and what's the weather like and the traffic, and we're going to incorporate these different data sources in Geneva. There is so-called Système Information Territoire Genevoise, Geneva Information System, which we're going to integrate into following the individuals in daily life with their wearables. By the way, how many of you have a wearable? At least one. Well, so next time when you go to the doctor, and the doctor, sorry, looking at the doctor, next time when you go to the doctor and you point out that you have a wearable and why this person is not yet looking into your data and where your disease happened and what happened and how you should take your medication and what needs to be done next, and this person will look at you with big eyes and saying, like, can we just stick to clinical guidelines? Then please also blame, who shall we blame? The system, the acceptance, but also please point out, like I want to point out, we still work on the validity of these different data sources. I have right now three, sometimes four, but today 3, different devices, and at the end of the day I have different number of steps, and the duration of sleep doesn't match, right? And there's this different elements which we are not yet figuring out, and it will be consolidated and the data will be integrated. Just give us time, but also help us in do our science. Thank you.
I've been there. I went to my medical doctor with my Oura ring, my Sunto 9 Peak, with my fitness tracker. She looked at me and said, no. And actually, I asked Thierry about that, and he agreed somehow with my medical doctor. These are not precise enough. But Now I have another question for you, because you challenged me on this wearables thing. AI tools are trained with my data, and clinical decisions are complex processes. So how can I benefit from that?
I think this is a very important point, because it will probably drive the acceptance of people and the adherence of people to that kind of new technologies. But again, I'm saying what I said before. The problem is that data doesn't mean information. And I think we are overflown by a lot of data that are useless. I'm an intensivist, and you know, in the intensive care, when you have a patient, you have hundreds and hundreds of data. Alarms and whatever, and only a few of them are really very important. And one of the problems that I see currently is that we are overwhelmed with data that bring no value, but it's very important. Let's work together to see what kind of data are in the end bringing added value to the patient. And I think that for the patient, of course, if many data or information that the physician do not have access yet can be brought by this kind of technology, not only wearables, but just, you know, what we call patient-reported outcome or patient-reported experience. For me, it's more important that someone tells me, you know, I do not sleep well, instead of showing me that the device is telling him or her that she or he is not well, good sleep. I mean, that's something that is very important. So I think the value that in the end the patient will get is that he can share many information, many data with the patient, and AI will help us to draw information, valuable information for the physician and the patient to then act to add value. I think it's a challenge because I can tell you in modern medicine, we have a lot of toys, but we don't have many tools. So differentiating the toys from the tools is something I'm fighting every day with my colleagues. And people love toys, and physicians particularly.
We love them too, because at one point I realized I rely much more on the Oura Ring telling me how well I slept. And then I heard a study from Stanford speaking about the placebo effect when you look at your sleep score in the morning. Although you slept well, if the bloody tool is saying you had a poor quality sleep, then, oh my God, I'm going to stay home, I'm not working, I'm not doing anything today because I'm a wreck. And wearables, it's one of the things where we discuss quite a lot, Kate. We had a very passionate discussion. Why? Because we buy the device, and then we send the data, and as a reward for us, we have to pay a subscription to understand something about our data. Is this fair? I know we agreed it's not, but let's elaborate on that.
It's not fair because it's not working towards advantage. Actually, the current services for those of you who have these devices, it's a lot of time series. It's a time series with some annotation, not a binding from perspective of implying some specific behaviors, because that's where the manufacturer will get into trouble, right? Have you heard about recently what was the device which got into trouble? The blood pressure one, I'm forgetting. I'm wearing a blood pressure, continuous blood pressure, but it's another one. I'm wearing Hilo, the other one got into trouble. Anybody knows which I'm talking about? I forgot. Never mind. It's like we have tons of time series, and then it's up to us to make up the information and the knowledge and get the wisdom of what needs to be changed, and really do this N of one kind of trials where we try different things and see what works, what doesn't. And also I would make you aware of this advanced metrics, sleep metrics, even sleep stages. Please do not pay attention to those. This, I promised my colleagues at Stanford Medical Center when we work together, sleep happens in the brain and the hands and everything else is too far. It's too far, please, it's too far. It's some kind of estimate and it's too far, and please do not believe in sleep stages. Do it for science. But the sleep duration is more or less okay, and then the physical activity, the bouts, like overall volume of physical activity, but do not again look at the steps. So again, let's get back to science. What's missing? I chopped some notes. What's missing? We have this individual level models and tons of minute by minute data sets, and we are missing the really accurate models and validated models to map it on population level models, epidemiological level models. What happens if I keep continuing doing my 10,000 steps, which is, again, we all heard 10,000 steps, it's a myth. What happens if I really sleep well and everything and I eat? How does it really change my future behavior, of health and quality of life state? We do not have yet validated models. There are different underlying distributions and really assumptions, and really different groups are working on this, and we're all busy working on our things. We do not have yet time to really validate these different models. Then, that also relates to timelines, right? The short term, like this 10 minutes, this 1 day, this 10 days. How does it relate to the fact that somewhere in the future I'm already building this damage in my body and something will happen? And the context, we're missing context. Unfortunately, as I said, fortunately, at least my lab, I was like, well, we need to get environmental aspects and the weather and really the noise and the temperature when you're sleeping, and all of this needs to be collected. However, this is mostly missing, and I'm sorry to say, as much as PROs, the patient-reported outcomes, the self-reports are there, but they are totally missing the context. In many cases, it's in last 2 weeks, how have you been feeling, and how much you've been walking, and how many days of you've been active, and how many days you've eaten vegetables and fruits in type 2 diabetes. So that's where we're adding the context, which is more important. It's more difficult because it adds additional variables, right? And then really we're getting, also in my lab, we're getting beyond the correlations, because there have a lot of correlations. Or the moment when we look at the UK Biobank or these longitudinal studies, when we have some data, not much variables, then we get into correlations, we write our papers, but we need to get into causality. What really causes what at which level, right? And then it goes back to timeliness, different elements of I feel bad today, I feel bad tomorrow, I feel good, I do this, I do that, I eat that, I don't eat that. It's all correlated, but also there's causal loops, and we're still discovering them. So I think I'll stop there, but there will be benefit from data. If you want to join my lab and come and collaborate on different data sets and really working with a statistician or data science or something, please come in and let's do it together. Thank you.
Thank you. Thank you very much. Caroline, the next question goes to you, because we know sometimes patients pay out of pocket and we still need their data. So how do we implement a system where patients can benefit from the data they share without creating inequalities?
Okay. So let me go a little bit back. So when we speak about data sharing and health and benefits, we often hear the phrase "data is the new oil." Okay, but at least from a public health perspective, I don't agree with it. I'd say more it's like clean water. It only creates value if it flows safely and benefits everyone. And I think that's the approach we see. The real value of data in public health lies in, better public health decisions, being able to aggregate data, identify gaps in access, guide better investment decisions. So I believe data dividends should not be at the individual level, but at the system level. And when we have data there, we can also correlate health data with non-traditional data. So we do some work around space and global health. And often when people hear space and global health, they think about, going to space. Yes, there are some applications, but in general, we do a lot of work around using satellite and Earth observation data and how we can use it for health. And there are so many use cases. You can correlate the data to NCDs in cities, to noise, to heat, and so on, but also in a global health context. A very concrete example is using satellite images to analyze rainfall. And then if you're in a malaria endemic region, you can predict that there's going to be an outbreak, so you can bring the medication that's needed. You can better plan the response to this outbreak. And I believe that when people see that their data and the other data that is available in a system leads to better outcomes, that's when they start to trust in the system and are willing to share more openly their data.
This is a very interesting perspective because as a patient, I only thought in my selfish way about my own dividends, but your perspective is totally new to me at least. However, we need to educate people in this respect and explain that this is possible. It's the first time I hear about that myself. Fascinating. Let's close this session before we go into Q&A with one question, and I kindly ask each one of you to answer. Maybe I'm starting with you, Caroline. What is one single most crucial factor for having success from patient perspective in implementing decentralized data sharing?
I think, from the patient perspective, we can have the best algorithms, the best tools, and so on. And the most advanced system, but without one thing, it's going to lead us nowhere, and that's trust. So we really need to make sure that, the way we design the systems integrates the patient perspective and creates the trust and the added value for the patient.
Well, that was challenging. One thing, human-centric design, and from the beginning, and not as a patchwork, where at some point in the process, the engineers ask the users just because they have to about their opinion on this new product. From the beginning, when we design, when we even think about any solution, we have to understand if the pain point, if the need is real, and working with the user, but actually listening what's the pain point, what's the need for which particular need we design. So human-centric design as a basis, and not just a factor which is a patch after. And in this spirit, I'm educating my students with qualitative methods, talking to individuals, patients, non-patients, collecting data through interviews, surveys, observations, focus groups. Thank you.
Short version, nothing to add. No, I think it's very important, trust, that you really own your data, and also that in the end you will get something back, individually and collectively. And individually, it means that, remember that data are no action, they don't cure. It's just a way to understand how to cure and how to act preventively or when you're sick. And second, in the community, and everything that was said is very important, we can add a lot of new information. In the moment, we don't know exactly, you mentioned climate or environment and all these things. So I think the gain that we will have at the individual level and at the community level, if we work correctly, I think it can be huge. But we must trust and be sure that the patient owns relevant data.
Wonderful. And I thought only insurance is the boring part that has no user centricity, human-centric design, but it seems it's the same in healthcare. I would love to open the floor for questions, so please don't be shy. I'll come with the microphone so everyone can hear you.
I would have millions of questions, but then we will have the entire evening. So thanks to the panelists, because it was extremely interesting for all the data discussion, the wearables, and I love the Thierry quote. We have a lot of toys, but not that many tools these days. It's really, and I will start from that point. We have a lot of toys, not that many tools. And also for Katarzyna, I think is the question. Do we have a way to make sure that the data that we are acquiring, also thanks to all the population, the wearables, for instance, have the right quality? The certification of those wearables, is it a way to go? Will it influence or give a step change to the data we are acquiring? So I would like to see what is your opinion, the opinion of the panelists. And the second question is, these data, this production of data, these wearables, are accessible to a certain type of population. Don't we risk to skew the data and generate models that helps us to predict based only on a part of a population? That's my questions.
Absolutely, absolutely. Excellent questions. In 2018, in my lab, we have looked into 430 different devices, wearables on the body, which you could put 12 on their feet, and I guess we will not be able to walk, but all of them, they claim to monitor activity. And there was so much how do I say, toys, right? We've been looking into the validation level, and there is analytical validity and the sensor validity, and then really the algorithmic validity, and then there's a clinical validity. And many of them were really at the level of toys. And actually, one clinician many years ago told me in the face, you computer scientists, you play with your toys. So you're right, yes. It's something which is, because of the miniaturization, because of accessibility of these different tools for designing the new hardware, and really the battery and the connectivity and everything, it's so easy, and easy meaning accessible, and then you have all this really tsunami of these devices which are really, really bad quality. And unfortunately then, I'm still not telling you that based on validation, you will really assure bulletproof endpoint. You know, in clinical terms, we talk about endpoints. If you put something in clinical trials and say, I really make sure that somebody has a better quality of life at the end. Right now, these endpoints are exploratory, secondary exploratory, and also they are very much related to what you pointed out, self-reported, patient-reported outcomes with specific so-called recall period. In the last 2 weeks, have you been doing this or that? Or in the last week? So then we get into wearables. Everybody's wearing wearables. Why don't you have wearables in all these clinical trials, right? Because they are not validated, but also there's so many human factors. So many human factors. If I don't put my device accurately, then the data is going to be garbage. And then you as a pharma, you invested, I don't know how many millions, and you give me there was a drug, right? There was a clinical trial, and then half of the patients, because they don't like I had patients in the face telling me that they don't want to wear our research device because they have a Rolex, right? So it's like, you know, I mean, this is extreme, but, you know, they may not like the color and the shape, and it's stigmatizing. And so it's really something which we cannot assure. There's so many human factors. But I have a good news. Good news is that some aspects has been mastered. How many of you know continuous glucose monitor? Anybody was trying, right? The little patch. There is a lot of digital endpoints in type 2 diabetes and obesity trials right now where the FDA EMA is requiring to get continuous glucose monitor. We kind of master it. You patch it for 2 weeks, is there, and yes, it can fall off because you use oils, or you put it on the muscle, and yeah, I mean, we've been testing a lot of things. But somehow it becomes this, you master the body, right? And also another, it's polysomnography at night. Some set of devices, I'm not talking about the whole setup, but there is also home-based polysomnography. Somehow we're starting to master the body at night, how to measure and how to collect this physiological data, biophysiological data and functioning data at night, which then could be really taken seriously. And the day is a mess. So not yet, but we're working on this. Join us. Thank you.
Maybe I can. It doesn't work. I can add that you know, nothing new in science. You know, the accuracy of data and the reliability of data has been an issue for centuries, and garbage in, garbage out, and that's one of the problems. And you know, in the intensive care, which was my world before, the number of toys that we had that were developed based on not accurate or I mean bad data is just huge. And I don't think it's different in all these sensors and all the things that we are inventing. I mean, again, data is not information, and data is not curing anyone. It's just that we have to see what is really brought as an information, and is this information actionable in something that will change the outcome. And the example of glucose monitoring is very interesting because it has changed really the life of many diabetes patients, type 1 or type 2, because they are now, they can live completely normally without having issues with their blood glucose level. And so that's a very interesting point. Again, curation of data is probably one of the most difficult challenge that we will have in front of us.
Hi, Salim here from WHO. I want just to show that, like, actually, because Mirela complains about like that insurance is not very important. Like, because we talked about blockchain before, And like what in here, we heard about data and everything here, but like for example, like concepts like smart contracts, allowing like payment to happen automatically after conditions are kind of put in place. Like so, actually, like in this kind of like I don't know if you heard about smart contracts in blockchain and so on. So that can be applied easily to execute and to like make things happen faster. I want just to ask the panelists is like if there is, because the fact that you decentralize the data, then you bring in an ecosystem, for example, blockchain or this kind of ecosystems that allows you to actually use this kind of like concepts. I don't know if you heard of any of this kind of concepts being used, in real life. Smart contract for like execution of like certain aspects once or algorithm after the data have been kind of fulfill like certain conditions.
Well, actually, that's an excellent question, but Carmen just says that's going to be covered in the second panel. And I can assure you, in insurance, we don't speak about these sophisticated things yet. Anything the panelists want to add?
If I understood the question correctly, are you looking forward to understand what's the value of the phone as a sensor? Because I can comment on this. No, it's more. Okay. Sorry.
So for the more technical panel, Carmen will answer and her guests will answer in the second part. I would have loved to have more questions from the audience. You can still ask them because we're going to go in a break, if I understand correctly, and they are here. So thank you very much. It's been really a pleasure discussing with you today, and thank you for the questions. Let's continue in the break, right, Steffi? Are we allowed to go in a break? Not without you. Thank you.
Thank you very much for the panel.